Good afternoon. I want to welcome faculty, students, and staff who are attending, and I want to welcome everyone who's watching on Zoom. This is going to be a panel discussion about the health impacts of COVID-19 outbreak. In late December, public health officials began sounding the alarm about the emergence of a novel coronavirus, which we now refer to as COVID-19. In a short time, this new respiratory disease, which was first detected in Wuhan, China, quickly spread to other parts of the world. There are many things we still do not know about COVID-19, including some of the aspects of how fast and how far it will spread. This afternoon, we've invited experts from the Johns Hopkins School of Medicine and Johns Hopkins Bloomberg School of Public Health to provide insights on the illness and the response at Johns Hopkins. I'm going to lead the discussion, and you'll have the opportunity to ask questions following the discussion. I want to first introduce our two guests. First, we have Jennifer Nuzzo on the end of the table here. Jennifer is a senior scholar at the Johns Hopkins Center for Health Security and an associate professor in the Department of Environmental Health and Engineering and the Department of Epidemiology at the Johns Hopkins Bloomberg School of Public Health. An epidemiologist by training, her work focuses on global health security with a particular focus on outbreak detection and response. And prior to working at the Center for Health Security, Dr. Nuzzo worked as a public health epidemiologist for the city of New York. Immediately to my right, we have Lauren Sauer. Lauren is the Director of Operations for the Johns Hopkins Office of Critical Event Preparedness and Response, also known as CPAR. CPAR serves as the command center for planning for and reaction to any type of disaster at Johns Hopkins. Lauren is also on the faculties of the Johns Hopkins School of Medicine and the Johns Hopkins Bloomberg School of Public Health. She's a core team leader on the Johns Hopkins GO team, a deployable medical asset. She's worked remotely and on the ground for several disaster responses, including Hurricane Katrina, the 2009 California wildfires, the Haiti earthquake, the Pakistan floods, and more recently, the Ebola virus disease outbreak in West Africa. So, we have very good expertise here for questions this afternoon. Before getting into specific questions, I know that every field, including business, has terms that are specific to that field. And so I think it's going to be important for us to hear from our two guests what are some very specific terms, either medical terms or public health terms, that we should know in order to make the discussion this afternoon more useful. So I'll turn it over to the two of you to elaborate on that, because I know you've got a few things you want to share first. And if you want to turn your microphone on when you speak, that would be great.
Sure, and this is to control the slides here. So we just put together a few slides, and Lauren, I didn't know if you wanted just to start talking about this this graphic here, the map, and what it means, and the case numbers.
Sure. So I think everyone has seen this probably. It is a product of the School of Engineering at Hopkins, and it is very impressive that this was one of the first ways that we as a global community were able to understand what the case counts were looking like. And I think we really benefit from having the faculty at engineering create something like this that is now used globally and has been adopted by several global CDCs, various NGOs, and the WHO has a very similar map as well. What it shows basically is the current case count in red, and then the death rate and the number of deaths and the number of recovereds. And you'll notice that there's a big gap between those numbers. And part of that, which we'll talk about, is because a lot of people have not been dispositioned from the hospital. They basically have not cleared the hurdle to get out of the hospital with those negative tests that you need to be noted as cured. So we'll talk a little bit about what that means in a global sense at the individual level, and then we'll just talk about what these numbers and what this map really means for us here at Johns Hopkins.
Yeah, and I just want to credit Lauren Gardner at the School of Engineering for putting together this map. This was the first geographic representation of cases that was produced, and it preceded WHO's own mapping. So it's, I think, a real point of pride for the university that we contributed an important resource in this way, and just shows sort of that we're on the kind of leading edge of following this issue. So where we are now in terms of our understanding of the virus. And I have to stress that there are still many unknowns, and some of what we know now is not what we thought a month ago. And so that's just part of what happens when a new virus emerges and we're trying to study it and understand it in real time. And so just want to caution that everything we're saying today is based on our current understanding. This may be subject to change. We'll try to kind of qualify our statements as best as we can, but just recognize that, we might be finding ourselves in a different situation in a few weeks. But the takeaway that you saw from the map and on this slide is that we are now in a situation where there are upwards of 70,000 cases being reported worldwide. The majority of those cases are being reported by China, but nonetheless, about 25 countries have since reported cases. And where we know cases to be is in part determined by how countries are looking for cases. And so we shouldn't take away from this map that if a country is not listed, that means it doesn't have cases, or that how many cases a country is reporting means that they for sure have more than their neighbors. It could be very well influenced by how they are testing and how they're looking and when they began testing, et cetera. So still some information in flux, and it makes it kind of difficult to say for certainty that we know where in the world the virus is. And that has importance, I think, for how we think about controlling this virus, which we'll talk about. One thing I like to stress when I talk to groups such as this one or reporters, that it's not so much the number of cases that we worry about. Certainly more cases there are in the world. There are challenges for public health, challenges for healthcare, challenges in terms of thinking about how to control the virus because there are just more opportunities for spread. But really what I think is the point that we are fixated on at this juncture is how severe are the illnesses that are produced by this virus. And that's where there's some degree of uncertainty. If you simply took the number of deaths that have been reported and divide that into the number of cases that have been reported, you would come up about a 2% case fatality ratio. I do not believe that that is a true estimate of case fatality because of the way that we are conducting surveillance for this virus. It is very much biased towards finding people who are ill enough to seek medical attention, possibly severely ill, and so we could very well be overestimating the severity that's associated with this virus. We now know that of the 70+ thousand cases that have been reported to date, it's estimated that about 80% or more of those are quite mild. And so when we have a virus that causes symptoms that are fairly nonspecific and look like other viruses, and when the majority of the people are infected have symptoms that they may mistake for a cold or something else, it's very unlikely that we would capture those people unless they happen to seek medical attention and if they had other risk factors that would make them good candidates for testing. So we don't know for sure, but I think a number of people, and I'm certainly in this category, and not everybody feels this way, but I feel that the true case fatality is probably much lower than this 2%. Nonetheless, 2% from a public health standpoint is an enormous percentage. That's on the order of the 1918 influenza pandemic. So because of the possibility that this could be, even 1% would pose burdens on health systems across the world, that is why this virus is getting the level of attention that it has been getting. And just to say that I already referenced the 1918 influenza. Seasonal flu, you often hear comparisons to seasonal flu, and people are often urged to judge their risk of acquiring the virus and being infected with the virus with respect to their risk for other viruses. Certainly seasonal influenza, these are data from the CDC for a particularly bad flu year, to show that other respiratory viruses that we deal with every year do cause high numbers of critical illness, hospitalizations, and deaths. The question is, where does this virus fall in relation to those? Not to say that if it, like I said, the absolute numbers can be challenging for public health and healthcare and are warranting of attention in their own, but when you're thinking about how we gauge global risk and individual risk, we need to hold this in relation to other viruses that we deal with on a daily basis that don't necessarily prompt sessions like this. As I mentioned before, I think there are some biases in the way that we are conducting surveillance, the way that we're going out and looking for cases. And this has relevance in two ways. One, as I mentioned already, we are tending to test people who are seeking medical attention. And so by definition, those are potentially people who are sicker than potentially other people who are infected. However, in many countries, we are also trying to test people based on whether or not they have a connection to China. So in the United States, and here's just a definition of, or sort of the criteria that you have to meet in order to be tested for coronavirus here in the United States. If you're not a contact of a known case, you have to be someone who has traveled to Wuhan, China specifically, and have a lower respiratory infection. So if you have a runny nose and maybe a low-grade fever that may not, and you've traveled to Wuhan, you may not get tested depending on how people are going to be interpreting that. And if you are somebody who traveled to broader China, not Wuhan specifically, you have to be sick enough to be hospitalized for your lower respiratory infection. So what that means is if you don't fall into any of those categories, you're likely not going to be counted as a case, even if you're infected. And now that we have 25 countries reporting cases, we have seen many of those countries have found cases that have resulted from local transmission. That means that if you were someone who became infected from somebody not from China, you are likely not going to be captured in most countries' surveillance approaches. So that makes it very difficult for us to know where in the world the virus is because we are only testing a small potential portion of infected individuals. Now, there's a hope that countries will start to expand their surveillance efforts. There have been some technical challenges and operational challenges with that. The United States has said that it's going to be expanding its surveillance approaches, but so far that hasn't happened yet. But if and when we do, I expect we will get a much different picture of where in the world the virus is. And this is relevant because in the United Kingdom had implemented a ban or restrictions on travel from China and quarantine of people showing up from China. They experienced a case in a person who had never been to China but had come from Singapore, where there is local transmission. That person went on to infect 11 people on a holiday in France, and the United Kingdom essentially had to add a number of additional countries to their list of groups to target for screening. So if we are relying on geographic-based approaches to test people, we are only going to be as accurate as our knowledge of where in the world the virus is, and as you can see, there's a number of challenges to actually knowing where the virus is at this point. You've probably heard a lot about, particularly from governments and particularly applied to travel, this idea of like quarantining people. We've heard about quarantines on the cruise ships. We've heard of quarantines of passengers, particularly passengers returning from China, Americans who are returning from China. I just wanted to kind of clarify from a public health perspective what we mean when we talk about quarantine, because it's often referred to as a tool that we routinely do in public health, and it's actually not a tool that we routinely do in public health. Quarantine is different from isolation. I'll start with isolation. This is something that's commonly done. This is, we have found that we have determined that you have been infected with this virus, and what we're going to do is remove you from circulation, maybe have you stay at home if you're not very ill, or if you're very ill, go to a hospital and be isolated in a hospital so that you don't pass your known infection on to others. This is routinely done in medicine, routinely done in public health. There's an infrastructure to do this. We're familiar with it. The ethics of doing it are different because you know this person is ill and you know the risk that they could potentially transmit to others. Quarantine, by comparison, is actually not something that's typically done in the modern context. And what this means is you have an individual or a group of individuals that you don't know if they're sick. You don't know if they're incubating the virus and they're going to become sick. You just think based on something that they may have been exposed to the virus. And so that's what's happening with these cruise ships. Because there were some cases, the thought was potentially the other passengers on the ship may have been exposed and may ultimately develop infection, but you don't know. And this is a much different practice because you don't know, you're essentially holding people. You don't know if you are, in the case of the cruise ships, increasing their probability of becoming infected because you have not let them off the ship after a known potential exposure event. And it's not something that public health routinely does. And so when you hear in the press about, concerns or questions about quarantine, just to recognize that part of that debate is over the fact that this is not a routine public health measure. In public health practice, at least in the US, it's very rarely done. And the most recent example I can think of is if you have like an insular community that refuses to vaccinate and you have a measles outbreak, sometimes that insular community that is probably already keeping to themselves anyway, you would quarantine them for the full incubation period of the virus, simply because they refuse to vaccinate other people, and you have no other means to prevent their transmitting to others. But it's again a very rare measure. So there have also been public debates as to how we are responding globally to this virus. And to date, most of the global response, that is measures that countries are taking, including what they're doing internally, like in the case of China, restricting the movement of more than 600 million people, as well as what countries are doing outside of China to potentially prevent the importation of the virus or to limit the importation of the virus. Much of what they have been doing has been aimed at containing the virus. And in public health terms, when we talk about containment, what essentially we mean is we are implementing control measures with the goal of absolutely stopping the spread of the virus. So in the 2003 SARS epidemic, which affected a number of countries across the globe, it was possible they were able to fully contain the spread of SARS, stop it from spreading. As far as we know, SARS is gone from the planet. Now, the virus that caused that epidemic is very different than the virus that we are seeing now for a number of reasons. This virus tends to produce milder symptoms. It seems to be more easily transmissible, and it seems to be transmissible by people potentially earlier in their course of illness. With SARS, people didn't tend to transmit until they were quite ill, and so most of the transmission occurred in and around health facilities. And so it was a bit easier to contain because once we got better at doing infection control in health facilities, we could potentially reduce transmission to healthcare workers and reduce transmission to their contacts. This virus seems to be spreading much more in the community, and although there have been healthcare worker infections, they're not the majority of the infections reported to date. And so what that means is that this virus, in many ways, is much harder to contain than the virus that caused the SARS epidemic of 2003. So that raises the prospect or the question as to whether it's even possible to contain it, whether we can take enough measures to stop the spread and prevent it from reaching different parts of the planet. I'm of the belief that it is not possible, and that we are in the early stages of a pandemic. Now, I have to say, when I say the word pandemic, as an epidemiologist, what I mean is I am referring purely to geographic spread. That word is scary, and it's used in movies, and that word is not a proxy for a deadly apocalyptic virus, even though that's how it's depicted in the movies. I am simply meaning that it will be in multiple parts of the planet. We have experienced a pandemic in recent years. In 2009, a new flu virus emerged and spread around the globe. And in 2009, in 2 months, that virus was essentially everywhere. We had much more surveillance capacity in 2009 because we routinely test for flu. This is a new virus, and places don't routinely test for a novel coronavirus of this kind. So part of where I think the difference between then and now is that it's taking longer for us to get capacities into country to test for the virus. And I expect that if more countries were capable of testing, we would probably see the virus in a lot more places, and we'd probably be more open to calling what we're seeing now a pandemic. I bring this up for this group because in 2009, the virus emerged. We very much worried very early on that was it causing very severe illnesses. As more data became available, we started realizing that it possibly wasn't as severe as we thought. Early surveillance often is, for reasons I said, biased to find severe illness. And that virus is still with us today. Every flu season, we see the same virus that caused the pandemic of 2009. The difference is that we now have a vaccine that helps us protect people who are most likely to become severely ill and die from the flu. And efforts are underway to develop a coronavirus vaccine, which I think is important. I think in particular, it'll be useful to protect people who are in risk groups that would make them most likely to experience severe illness. At this point, our best knowledge is that that's people, elderly people, particularly over the age of 80, and people with underlying health conditions like diabetes and hypertension and other chronic illnesses. This slide is just to say that I think by WHO's definition, we are in a pandemic. WHO has not yet acknowledged this. Part of that is that they don't feel that some of the transmission happening in other countries is sustained community transmission. I think most people I talk to very much disagree with that assessment. So anyway, I think it's important for us to recognize and talk openly about whether containment of an epidemic is possible or whether we are in fact seeing pandemic spread, because my worry is that we're diverting resources from the community level work that we need to be doing. I think in the US context and in other countries, it's going to be very important for us to think about how we can protect those who are most vulnerable, think about making sure we don't try to isolate mildly ill people in hospitals. We want to reserve those beds for the people who truly require hospital care. I think we need to think about how we enable mildly ill people to isolate themselves at home. That's not easy if you don't have people to support you, get food, et cetera. And that's just a lot of, it sounds like not a big deal, but it's the same people involved in public health who would do that that are also now trying to quarantine passengers from China. So my worries have been that we're pursuing the wrong goal and putting our resources in the wrong places and not doing the important kind of preparedness work that we should be doing to focus more to mitigate the virus's impacts rather than to purely stop it from transmitting. So, and this is just really, Singapore should really be credited for very transparent reporting about all the cases that they are finding. They have very strong epidemiologic capacity, and they are, every time they find a case, they are doing a contact investigation of the case and trying to understand where these cases may be infected. They have had multiple clusters of cases that have resulted internal to Singapore. And not connected to travel to China. So just to say that China is not only the place where we could expect infections to occur. And as I've said, I think many other countries, were they capable of doing these kinds of investigations and testing, could find similar phenomenon, similar transmission occurring. So I already talked about this, sort of focusing on the path forward, which again, I think we need to just think about protecting those who are most vulnerable and certainly isolating ourselves if we're not feeling well. This is always a good idea. I mean, just generally, if you have a fever, stay home. Just stay home. You'll do everybody a favor. If it's not the coronavirus, it's probably the flu. The flu A is surging right now. We have yet again, another strange flu season. And if we can reduce the number of flu illnesses in the community, that will just spare healthcare resources for if we see an uptick in coronavirus infections. So it's a good thing. All the, hand hygiene, it's always a good idea to wash your hands. And it's always a good idea to just think about how you can not transmit illness to others. Now I'll turn it over to Lauren to talk about what the university's doing.
It's always nice to hear a little bit of voice of reason from you. I think one of the things that we've been struggling with at the institutional level is how to communicate that we are doing preparedness activities and we are aware of the risk and, to the extent that we can be, and that we are working behind the scenes to make sure that our community is safe and protected and encourage people to not overreact, but also not underreact. And so, I think when you watch the news or read the newspapers or however you consume news media these days, it feels a little dire. And I think part of that is something that Jennifer and I have talked about previously, is that we are in an election cycle, and there are points to be made about how we talk about things like public health in those news cycles. We saw this in 2014 Ebola outbreak, and as soon as the election was over, so was the coverage of that outbreak. So I think it's always important to take sort of the information that you're receiving, particularly from popular media sources, with a grain of salt. That being said, we are doing a lot of work here at Johns Hopkins to make sure that our community is safe and protected. And it's not just at the university, it's at the health system, and it's at all of our affiliate entities. And we want to have a concerted effort to ensure that our response is supportive of everyone in a meaningful and real way. So we have activated incident command at the health system. We actually reduced the scope of the incident command at the health system because we feel like we've done a lot of preparedness activities. The same has happened at the university leadership level. We activated incident command, and we were able to come down to a maintenance level, which is a really great feeling. My background is in emergency preparedness, and it's always nice to know that you have a structure in place that operates like a well-oiled machine. You don't want the first time you communicate with your team or with your support, your community support, to be in the midst of an emergency. So Hopkins has had a history of preparedness and has always, not always, but has, as long as I've been here, which is 16 years, taken a really strong approach towards structuring emergency preparedness and response. And I think we're seeing that in this outbreak as well. We have created significant amounts of guidance for every member of our community. We acknowledge that every member of our community is touched by this outbreak in some way or another, whether it's knowing friends and family in the affected region, whether it's coming from the affected region, or whether it's just not being sure of what's happening and how you should react and the potential risk moving forward. And so we have created guidance on the university side. It's hosted at the hub, which I'm sure everyone's familiar with, but the link is right up there on the slide, to walk you through what Johns Hopkins is doing. An example of this is how we're screening people who feel that they may have had exposure to the coronavirus. We've set up call systems in place for students, staff, and faculty so that if you're not sure if you've been exposed, or if you're feeling unwell and you want to verify that you don't have to go to the emergency department because of your exposure risk, that you can actually call the student health department or the university health department or our occupational health department for faculty and staff to ask the questions, to go through the screening, and to make a determination with a healthcare provider as to whether or not you feel like you need to have additional screening and possible testing. This is important because, as Jennifer was saying before, those epi links are not as strong as we want them to be. So when we do surveillance in these early stages, it does gear towards more ill people, and it gears towards these non-clinical elements. So the travel history, for example. The travel history is not going to be as reliable as the spread becomes broader. It's just inherent in how we do surveillance and also how people contact each other. So we have set up these systems in place so that it's not up to the individual to interpret the CDC guidance or the state health department guidance. We have medical professionals who know how to interpret this guidance, know how to assess risk to the best of their ability, and can help link people to care whenever it's appropriate. In addition, we're doing things like town halls and these seminars to make sure people have the most up-to-date information on the virus, on the global activities around it, and on the community level activities at Hopkins. We've set up an email address through the CPAR. It's just cpar@jhmi.edu, and people can email their questions, and we'll absolutely get answers within 24 hours. Usually it's within 1 to 2 hours, assuming it comes to my phone or my computer efficiently. Sometimes things get clogged up in those Hopkins pipes, but the emails have consistent messaging about what is going on, what Hopkins is doing, and how Hopkins can support the response to those questions. And the purpose of that is so that we can make sure that those emergency resources that we do have, like the screening, like the emergency lines, like our incident command system, are protected from general questions. We completely appreciate that people will have general questions, and perhaps it's a question that's specific to your interaction with a Johns Hopkins entity, but you don't necessarily want to call the provost's office or your professor or your occupational health physician, and you just want a general question answered. That is absolutely a reasonable request. And I think so far it's been a very straightforward thing to provide, and I think it's been really helpful to the Johns Hopkins community to have their questions personally answered. So I would encourage everyone here to take advantage of that if you have very specific questions, but not necessarily urgent questions. We've also worked a lot on making sure that we're supporting our community members. One of my favorite things about Johns Hopkins, I have been here a really long time, and I absolutely love it here, and I think the biggest part of that is because it is a global but really local community. So Hopkins has unbelievable global reach. We have students, faculty, and staff from all over the globe. And yet here we are sitting in a room together in East Baltimore having a conversation about something that's affecting the entire world. And I think the level of the effect of this virus is really different from student to student, but as a community, we can come together and support each other and provide a level of both professionalism, but also care and personalism, or personal relationships that, I don't know if personalism is a word. Maybe we'll edit that out. Build these personal relationships that allow us to support each other. One of the things that's really hard in these early outbreaks is that lack of information can create fear, and it can further fear, and it can create places where misinformation and disinformation can well up. And the importance of things like this event and the hub resources and the CPAR website are to really make sure that we are providing factual, up-to-date information to everyone at the Johns Hopkins community so that we can support each other to the best of our abilities. We want to make sure that we are not letting fear move towards xenophobia. We are not letting fear move towards racism, and we are not letting fear move towards people making rash or inappropriate decisions about community members that we are here to support. So we've done a lot of work in that space as well. It's not just operational response, but it's about how we can support our community and how we can make sure that we're coming together to either do response to this outbreak or to maintain our basic business continuity and day-to-day operations and continue to provide education, continue to provide training, continue to provide the world-class environment that people come here for every single day. So maybe I'll leave it at that since the resources are up on the screen and we can take some questions.
Great. Well, first I want to thank you for that very helpful explanation. It's great to hear some basic definitions that not all of us are familiar with and to understand some of the terminology. It's great to understand that there are some very basic things that each of us can do to protect ourselves and those around us that are just basic common sense. And I think it's very helpful for those of us who don't see what's going on behind the scenes to hear about some of those things and understand the university really is taking a very active role here. I will turn it over to people who are in attendance for questions in just a moment, but one question that I want to ask to begin with is, I've heard a few people who are very concerned about travel even within the United States. Is that something we should be concerned about at this point?
So, no, I don't believe that it is.
Okay.
No, I don't believe that it is. Of course, as I mentioned, we don't really have a great sense of where in the world the virus is, and I do believe that there may be cases occurring in places that we don't know. Based on the data that we have, no. And also, we do know that there's a lot of influenza in the world, including in the US. And so if you wouldn't postpone your trip for influenza, I'm not sure that it makes sense to postpone it for the COVID-19. That's my point. I mean, I think if there are people who are in very high risk patterns and we do ultimately get more information about where, about the virus being in the United States and places that we hadn't previously recognized, then maybe that's an important time to assess whether the trip is necessary. But I think for the most part, what we don't want to do with this virus, we of course want to make sure we protect ourselves and we protect public health. But we don't want to start acting in ways that make the toll of this epidemic, pandemic, whatever it is, worse than the virus itself, right? We have to go on with life. We have to continue to be productive society and help others and do the work that we have to do. And so we can't put lives on hold, particularly when, we don't have very, very compelling evidence of direct harm.
And maybe I'll just add to that, our travel guidance here at the university or here at Johns Hopkins is reflective of the best information that we have available to us right now. And so, like Jen said in the beginning, our guidance may change at some point, but right now we have an assessment that the internal risk in the United States is relatively low, and the travel guidance reflects that. It reflects that it is safe to move about this country, it is safe to attend classes, it is safe to come here or go there, and because we're early in this outbreak and we have been so focused on detection of imported cases, the cases are actually quite isolated from what we understand. And so I just want to reiterate that it is flu season, and so there may be fears about people coughing and sneezing and exhibiting flu-like symptoms because they are very similar to the symptoms that we are seeing listed for coronavirus. But that doesn't mean that everyone walking through an airport has it or everyone on your campus has it. And so making sure that you continue to use the guidance that we are putting out there based on best practices right now is really important.
Great, thank you. I think that's a very helpful start. Carey.
Thank you. I have a question. So what does it look like when the world can say it's under control? What does that mean, and what are those elements that everybody would feel more confident about?
Yeah, so we don't fully know. I think the best recent example we can look to inform us, and again, we don't fully know the extent to which this is applicable, but is 2009. And in 2009, there was certainly a surge of illness that over time tempered down. We don't yet know if this virus is going to have a seasonality in the same way that influenza does. There's some reason to think it might, but there's also some reason to kind of wonder truly what that's going to look like. I think if it goes the way of influenza, it might be a community-acquired virus that just continues to affect people, and I think that's where the ongoing research to develop vaccines and therapeutic drugs, particularly to protect the people that are likely to develop severe illness and die. One thing I have to say is that as public health, we look at percentages and we look at numbers, but numbers are not, like these percentages are not absolute. So I don't want to undersell the fact that there will be previously healthy people who are young who will develop severe illness and die. That is true of any respiratory virus that circulates right now. You don't hear about it, but it happens. And if you're a medical provider, you have seen cases of it. So I just want to put that out there so that when you hear a report of somebody who probably doesn't fall in those risk factor categories dies, we have to view that in context, again, comparing it to other viruses. Even there are coronaviruses out there now that are, it's a virus that causes the common cold. It's different than this virus because this is a new one. But even coronaviruses, the common cold virus, can cause severe illness in people and death in people. So we just have to hold those things in common. So I don't know what under control will mean, particularly absence of drugs and vaccines, but it's a little bit too early to tell. I think there are some questions whether if we see additional cases in other countries, or we recognize additional cases, whether it would look like China or if there's something unusual about what's going on in China. Just the reports. So far, there seems to be a discrepancy in what other countries are experiencing versus what China is experiencing, and we don't fully know why. And more research, of course, will be needed to understand that.
And just one additional point that I think you briefly touched on is that there's been a lot of comparison to influenza of this virus. And I think it's our nature as humans to sort of try and compare to things we know versus things we don't know, but that's really hard to do. And so when we think about what does control or success mean, it means developing these tools that we use to control influenza every year. So having a vaccine for this, testing out some of these therapeutics that may potentially work, but we don't really know. So there are clinical trials going on in China right now. Having a surge plan at our hospital that can increase our capacity if this does become seasonal, when these cases roll in. So all of these things, we're learning from the lessons of things like flu, even though it is very different right now. And when we build up those tools in our toolkit, then we can more successfully feel like we're responding.
It's interesting to hear the combination of comments throughout so far, because it sounds like one of the things about being under control, and particularly in comparison with SARS, the comparison you made earlier, is that it may not mean that the virus never appears again so much as that we understand what the risks are and know how best to respond. Yeah. And that's a very different form of control than we're used to thinking about. Nita, you had a question.
Thank you, Kevin. I've been talking to Kevin. I am Nida. I'm from second year of GMBA. I have been talking to Kevin about it for some time, about the response of students here on campus regarding this disease, and I've been very disappointed. I like your statement about how people should not underreact and also not overreact. I feel like people are underreacting right now. I talk to my peers and friends and the whole batch, and they tell me before WHO declared it as a global health emergency, they started telling me it's not in US right now, so why are you talking about it? Let's talk about things that we have control over. And they started comparing it with flu, saying that it has the same fatality rate as flu. Why don't you talk about that? And I'm like, okay, if I did not talk about that, that's my fault. And there are vaccines for flu. You can control the symptoms through antibiotics. This is something new. And, we have friends over here from China. They have families living back there. You need to care. You need to show some sensitivity, right? I have been talking to some Chinese friends, and they're like, people are like, so insensitive to them, I'm just so shocked at the response of people, because all these people go to these classes and we discuss these cases regarding ethics, how like pharmaceutical companies made unethical decisions and, for example, let the HIV affectees die in Africa. It was 10 million people, and they were fighting to protect the parents. And we discuss these cases and we say, oh, the companies acted unethically. And when something of a similar sort happens in reality, they show the same behavior. They seem to not care. So I'm very sure that these people are going to go to those same companies, big pharmaceutical companies, and they're going to repeat those unethical decisions. So I don't see it stopping anytime soon. I don't know how to change the mindset of people. And I was expecting a lot of people. No, I was not expecting people from my batch here. And as you can see, there's nobody from MBA here. The first years I've gone to IFRH, to other countries, they were very supportive of this. But in second year, they seem to not care, until it becomes an economic impact and it starts affecting your supply chain. Then you would care. Why not before that? Why do you want it to turn into an economic impact? Start controlling the effect of it before that. Human cost is the biggest direct cost. You need to care, and the economic cost comes later on. And I've been talking to a lot of people from other developing countries. I'm from Pakistan, another developing country. The case there is so bad, Until 2 weeks ago, we did not even have the testing kits to begin with. And China and Japan were the first countries to start providing us the testing kits. And we're really good friends with China. There are so many Pakistani people going back and forth from China, from around that region in Wuhan. And they're living with us. We are working with them, It's very impractical to assume that it's not in our country. And we don't have the quarantine facilities, so we're not bringing back our Pakistani students who are there. So the families of those students are protesting against the government. Why aren't you calling them back? And our reason is that we cannot call them back because we don't have the facilities to quarantine or isolate them. If it comes to our country, or other developing countries where it's very high population, the healthcare resources are not enough. It can spread like crazy, a lot of people will die because of it. But there's just not enough awareness in my country, and I know it's very bad. But the response of people here in America, whom I consider educated and developed, is just so weird. I don't think they're developed. I don't think they're educated if they do not care about other humans dying because of it, And like I've been talking to so there's this alumni I'm in contact with. She's working in Vietnam for a social enterprise, and she is spreading awareness about hand washing and how about it's more important than the mask itself. And they're setting up portable hand washing stations. And so I reached out to her. Joshua Barracks connected me to her, and so I've been trying to contact her, and she told me that I can start by reaching out to companies so that they can increase the supply of soaps so that we can distribute it to other countries. It's more important than masks. Washing hands is more important than masks. So I'm trying to work with her, and we might need to contact the companies to start producing awareness and hand washing videos that we can get translated and sent to different countries out there. Because I feel like if the companies do it, it will have a bigger impact than me do it. I talk to so many people, nobody takes me seriously. People have been literally hating me for it. They're calling me bad things and bad words. It's very disturbing.
So I just want to start by saying that the passion that you're expressing right now is the reason why this community is so important at Hopkins and more broadly. And I'm sorry that you've had the experience that your co-students, your colleagues, are not expressing the same level of passion that you want from them, or expressing appropriate responses, from what you're feeling. It doesn't mean they're not feeling it. And I'm not going to speak for any of your other students, but I think it's important to contextualize people's responses when they're afraid. And there is a potential that a lot of people are afraid right now. There's also a possibility that they don't care. And it's an unfortunate reality of the world, but the reason that you're here is to make that difference. And you will be able to take the passion that you're exhibiting right now and impact those companies, and impact NGOs, and impact countries, entire countries. I mean, I guarantee it, because the way you are approaching these problems, reaching out to colleagues, reaching out to friends, making contacts, identifying companies that can support operations in lower resource countries, that is why we're all here together to do this work. And it's so important. And it doesn't matter how many times your colleagues or other students or companies or government leaders tell you that the work is not important, you will continue to know it is. Because those little steps, they may feel really small and you may feel really alone. I think we've all been there, that we feel alone in this, something that we really care about and we really feel is important. And so you just feel like your voice is not being heard from the din of everything else that's going on in the world. I'll tell you one quick story. A friend of mine was trying to get HIV testing in an emergency department she worked in, broadly. We know that there's high-risk populations who could benefit from HIV testing. And her department chair said, look, I get public health issues brought to me every single day. Why should I care about this one? Why should I care about this one over that one, over that one, over that one? And eventually, she convinced her department chair how impactful a broad-scale HIV testing program would be, and it changed the way we do HIV testing in this country. And the things you're talking about that you care about so passionately may change an entire country's approach to infectious disease preparedness and response. And whether that's on the business side, the supply chain side, or just that human element, that you have a conversation with someone over coffee, a colleague that you met along the way, and they take an idea that you seeded back to their local government or their NGO or their company, and it makes a change that sparks potentially a global response. You just can't know right now. And so I would strongly encourage you to continue to spread the word about how important you feel that this is. But I also would encourage you not to be discouraged by what you feel like is a lack of caring from your colleagues and your students, because we just don't know. They may be going through a million other things that they feel like they cannot find just one little piece to prioritize this. And it may change, you just continue to have those conversations.
Anything to add, Jennifer, on that one?
That was beautiful. I think really well said, and I echo just my kudos to you for your passion. And one of the things I teach over the School of Public Health, one of the things that I try to teach the students in the class, we work on a lot of writing assignments, and one of the reasons why I try to teach writing is I say, you're going to find yourself at some point in your career, you're going to think like, I can't be the only one who's been thinking about this issue, who knows about these things, but somebody else should like be fixing this, right? And it may be that you are the person who has the most knowledge and the most passion, and you are the person to fix that. And so I teach writing as a tool because I think that's one of the ways to make change in the world. I think there are other ones I've been really encouraged by, just seeing like younger generations like running for office, trying to fix things. And this is just how things are changing. And I'll totally echo, not as a faculty member, as an epidemiologist, but as a mom, one thing that I feel like I've learned in my life is that, to Lauren's point about people going through different things, people just cope differently. And some people cope by just isolating it and not thinking about it, and that's just a strategy. And just to recognize that we all relate to these issues differently, and also feel part of the coping differences is sometimes we don't feel like we have a role to play, and then it's easier to just kind of wall it off. And anyway.
Yeah, and I'll just add one thing. I think what you said is really important. You may be the expert of all these people that you're talking to because you care so much about it. You may have learned more than they could ever hope to know because it's not their priority. And so then it is your responsibility to continue to try and educate them, but you're clearly making an impact, right? I mean, you absolutely are making an impact. Just the fact that colleagues are willing to link you to companies, they're willing to link you to governments, they're willing to support your ideas and listen and at least have the conversation with you, just getting them to have that conversation is such an important first step. So don't underestimate that for sure.
I think one of the important things that comes out of the two sets of comments there, particularly thinking about communication, we have a whole course on business communication in this school. And sometimes students wonder why. And what you talked about is very important. It helps to make a case. And I know there are many students going through it right now in our part-time programs, and they are having to make a case for something, and that's a very important lesson to take away. Other questions? Did we have any online questions for today?
No, there are no online questions yet, but I do have my own.
Okay, so make sure you get a microphone.
So, thank you. We've heard from other people that have spoken about our inability as a people to comprehend risk, that we assign risk differently. I'm curious, as this has unfolded, this event has unfolded, have you seen a change in that? Did you have more people calling you right away? Is that getting any better? Are people coming to realize that this may be something that they'll have to deal with long term?
So first of all, and this relates back to the earlier question, I had a call from a reporter yesterday. There's going to be some polling coming out. I'm not supposed to talk about the poll results. I'll just say that it tracks with what you've said in terms of levels of concern. I think that's in part influenced by how leaders are talking about this, and at least in the United States, leaders have been very optimistic in their messaging about things. I think CDC is now trying to shift its language a little bit if you pay attention to it, talking about not keeping the virus out, but eventually this is something that we're going to have to deal with, and you'll see a shift. But I think things will change when we find more cases. I think there'll be different issue. It's also partially, I think, driven by how much media attention there are on issues. I will say, I think we're in a little bit of a lull, like a little bit of a downswing right now. I don't expect that we will stay down. I think it'll go back up again. But the first few weeks, like the last week of January and the first week of February, were really intense with all sorts of inquiries, global inquiries, press inquiries. I mean, we were just going from one press event to the next. The Hill had a hearing. They actually have a couple more hearings planned, so they're still following this. But I think we're in a little bit of a lull, and it's not clear to me that that's at all tracking with viral developments. I think it's more just the news cycle and what gets attention. And I do think that the news cycle and what gets attention actually drives people's perception of risk, whether we like it or not. And that's one of the reasons why I've really prioritized talking to the media as much as I have, because I think it's important from a policy perspective to influence how issues are being talked about, but also for people who are just wanting to know what this means for them and their families. And, I think, anyway, so not sure I fully answered your question, but.
I agree. I think that the media inquiries have dropped off a little bit. I think that there's probably just a million other things drawing people's attention to the earlier point. But it is important to talk to the media because they're so unbelievably bad at assessing risk in like a, in a very real way, I think. And, there are some really great infectious disease reporters out there who are focused on that. I would encourage anyone who is interested in this sort of work to look at STAT. They do some really good ID reporting. But I think, I just think that sometimes when we try to assess risk and we're not getting anywhere because that information gap still exists, it's sort of like, I'm so exhausted, I can't do this anymore, I'm just gonna forget about it for a little bit. And I think that's that lull that you're sort of talking about, where there hasn't been a ton of, headline grabbing new developments that either increase our risk awareness or decrease our ability to assess risk, for the past few days. And so we just sort of let it drop off for a bit. And I don't know if that's good or bad, but
But I don't think it's over. I mean,
Yeah.
there's going to be something, and there's going to be another flurry, and just to expect that we will have peaks of this.
Yeah, I was kind of thinking in the context of the flu. We're in flu season. That's certainly a risk that people deal with every day.
Right.
And this has been equated somewhat to the flu. Obviously, it's new, but how do people rationalize that in their head?
My guess is in the U.S., there's a perception that this is a problem that's over there. It's not going to come here. And any worries that there had been was more about whether there could come here. And I don't think, for reasons I've already said, I think that's an accurate way to think of the current situation that we're in. And I think that will become more clear, and I expect people's level of concern or not will change with that.
Yeah, and I think people do like to compare it to flu just because it's a known entity. And so the risk of getting flu is pretty high this year, even if you are vaccinated. But they're not really comparable, especially right now when we don't have the tools that we were talking about earlier and we have this information gap.
Yeah.
So we're just about out of time, but I know between our panel on Monday and today, I did get one student who asked about, there have been conspiracy theories about this, about COVID-19, and for people who haven't had to worry about this type of issue before, haven't studied it in detail, a new virus arising is really nothing unusual. Or how you would put that in context to sort of help people understand this is just a part of what happens.
Yeah, so I believe that we sort of live in the age of viral emergence. I mean, if you feel like you're hearing about these things more on the news, it's because you are. There have been studies that show that the emergence of new viruses and other pathogens is on the rise, and there are a number of potential factors that influence why these things they usually jump from animals to humans. That's the number of factors. And then we live in a world that once that jump happens, and if the virus just happens to have the right genetics such that it can be transmitted between human, it can spread really quickly, depending on the specific pathogen. And so these things are going to happen for sure. So that to me is not uncommon. It seems like a breathless pace. I mean, I was very much getting lots and lots of press calls and speaking to the Hill for the Ebola epidemic in the DRC, which is still going on, despite falling from the headlines because of this. And it feels breathless and sometimes overwhelming. This is just a consequence of our lives on this planet. And why I work on these issues is I think they're important, and I think that there are things that we can do to make life better despite these trends. I think there are great people who are working on trying to understand that jump over point so that we can potentially prevent it. I think it's a long way off before we get there, but I'm really glad that there's a community of scholars and practitioners who are working on these issues. And I think life will get better, particularly if we harness passion and interest and abilities to focus on these issues.
I saw a really great headline yesterday, and it said, people are debating whether this came from bats or snakes or pangolins or a million other animals, but it doesn't matter because the animal that most hosts and spreads is a big slow mammal, and the author metahumans. We are increasingly pushing into areas that we have not inhabited, and I agree with you. I think we're just living in a time of emergence, and I don't think that's going to change anytime soon. So all the more reason that preparedness and response activities are so important, and it's so important to learn lessons from what we did wrong or what we continue to do wrong, and what we do right.
Well, thank you. I think we're out of time, and I think it's really important, though, to take away messages, and maybe you'll have a few minutes to stay afterwards if people have additional questions. But again, I think some things that we can take away. One, it's important to understand just what the risk is and how big it is, and we heard a lot about that today. Two, the importance of communication in many forms with people in all different types of contexts. And three, thinking about your reference to the era of viral emergence. I think it's an interesting potential headline for something, but it's interesting to think about what public health opportunities that creates, what learning opportunities that creates, and for the business school, what business opportunities that creates for people to think about how to either educate better, stop it from making that jump in the first place, or better ways and quicker ways of understanding and being able to reduce the uncertainty and reach that state of control, whatever that may mean in the long run. So I'd like to thank our two guests, and again, if they indicated they'd be willing to stay around for questions afterwards, but join me in thanking them.